Well, good afternoon, everyone. I'm Lloyd Miner, Dean of the Stanford School of Medicine, and I want to begin by again thanking Atul for being here this afternoon, and thank you for your wonderful lecture and this panel that I know is going to be very stimulating for all of us. Gil introduced Atul, but for those of you who may have joined just recently, Atul practices general and endocrine surgery at Brigham and Women's Hospital in Boston, and is professor both in the Department of Health Policy and Management at the Harvard School of Public Health and in the Department of Surgery at the Harvard Medical School. Also on our panel today, we have a very distinguished panel. To Atul's right is Charles Munger, Vice Chair of Berkshire Hathaway Corporation. Charlie is also an American business leader, as we all know, a lawyer, an investor, and philanthropist. Laura Carstensen,
Can I add one thing to that?
Absolutely.
The biggest reason we invited her too is 25 years as the chairman of Good Samaritan Hospital, a low-income hospital in LA.
Exactly.
Has a lot of perspective on it.
Well, thanks for adding that. Laura Carstensen, who's director of the Stanford Center for Longevity. She's also a professor of psychology and the Farley Dickinson Jr. Professor in Public Policy at Stanford. Robert Pearl, who's the CEO of the Permanente Medical Group and is also a plastic surgeon and is clinical professor of plastic surgery at Stanford and also a lecturer at the Graduate School of Business at Stanford. And Arnie Milstein, who's director of the Stanford Clinical Excellence Research Center and professor of medicine at Stanford, and also, prior to coming to Stanford, a leader in the value and quality initiatives around the country, founder of the Leapfrog Group and also the Consumer Purchaser Disclosure Project. So we want this panel not to be exclusively focused on end-of-life issues related to healthcare, but more broadly speaking, to be focused on the challenges of healthcare in America today. And we're going to solve that in the next 50 minutes or less. And what we ask each of the panelists to do in advance is to send us a 10-word description, a capsule summary of what he or she thinks is the major issue facing healthcare delivery in America today. And you see those projected on the screen in front of you. And I want to thank Manali Patel, who's an instructor here in the School of Medicine, who in real time is going to be adding in some thoughts on each of these areas as the discussion goes forward. What we thought we would do is ask each panelist, beginning with Atul, to, in a minute or so, comment on that 10-word description of the central issues facing healthcare delivery in America today, and then we'll open it up for discussion. So Atul, do you want to start?
Sure, and I believe your instructions try to do it in 1 minute.
Exactly.
Okay, so I'll try it briefly, which is, I think the underlying concept I've been focused on is the idea that the discoveries of the 20th century have exceeded our capabilities as individual practitioners to deliver on them. The volume of knowledge is too complex, and the capability of assuring that people actually receive the great discoveries that have happened require us to make groups of people successful in medicine, whether it's around end-of-life care, childbirth, surgery, or any of the range of areas that we try to deliver on. Our payment systems aren't matched to it, our teaching isn't matched to it, our systems are really not matched to it, and the challenge of this particular generation of clinicians that I'm part of, I think, is to make systems that can work for successful groups of practitioners and patients working together.
Charlie.
Well, I believe that if you don't like the way things are working, what you change are the incentives. It's just that simple, and we have a lot of the wrong incentives in medicine, and of course we're going to get a lot of outcomes we don't like.
Laura?
Well, I agree. I think what we're living with today really reflects the breathtaking success of the practice of medicine and the science of medicine over the last 100 years. Essentially, what we did in the 20th century was to bring premature death levels so low that now the majority of people living in the developed world are having the opportunity to grow old and to die as old people. So far, 100% do. And we haven't quite come to terms with that. So what is the role of medicine when people live out their full lives? And their behavior becomes very important. The kinds of diseases that people have are diseases that are rooted in lifestyles and decades of behaving, eating, exercising, or not exercising in a particular way. And the role of medicine comes to shift toward one that where behavior and thought and questions like the ones Atul was talking about come to play a major role in the practice of medicine as well.
Thank you. Robbie?
I was at the Oregon Health Sciences about 15 years ago and saw a sign that said quality, service, cost, pick any two. That's the 20th century. We're in the 21st century. And I believe that we now understand how to do all three, we just don't do it. Michelle Coey is in the audience, who leads our hospital work for us, and we've lowered by 30% hospital utilization, half of which was simply patient safety that Atul has written about. Hospital-acquired pneumonia, pressure ulcers, those types of things. We have technology today. Apple is a short distance away that we simply don't use to change how healthcare is delivered in this nation. And I like to think about the topics that Atul talks about as telling the truth. We don't tell the patients the truth. We don't tell them really what's going to happen. We give them, I think, often a false hope and an incomplete story. I think when we start telling the truth and using technology and focusing on quality, we actually can accomplish all three in the 21st century, and that's the challenge that we have, making it universal across the United States.
I don't dwell so much on the performance of the American healthcare system or any other healthcare system. I focus on what I think of as the first derivative of performance, which is the rate at which it's getting better. Not only better in better meeting patients' goals, but also more affordable, since at the end of the day, people have resources to spend on other things if healthcare takes more and more of their resources. And I think it's possible. I think that the kind of change incentives that Charlie mentioned would make a difference. And I think that investing a little bit more effort in not only investing our effort in biomedical technology innovation, which has delivered a fantastic dividend, but also a little bit more attention to the healthcare delivery vehicles on which we provide these biomedical miracles.
Great. Charlie, you mentioned incentives. Can you tell us more about what types of changes you would suggest we start to make in the incentive system?
Well, let's first talk about one of the most important incentives in all human nature, which is incentive-caused bias. If you're going to make money or otherwise improve yourself by some outcome, you will rationalize doing whatever is necessary to get the money. Now, it doesn't mean that every person is evil and that no Catholic archbishop is holy. But it does mean that by and large, incentives distort our cognition, and they do it largely on a subconscious basis. And that is a huge problem. And let me explain the worst version of the problem I ever saw, but one in medicine. When I was young, the sister city of my city had a doctor who was a very skilled surgeon. And he took the gallbladder out of every single patient that came near him. And after he had sent over several years a few bushel baskets full of perfectly normal gallbladders down to the pathology lab, the community hospital, with that discipline and level of quality for which they're so famous, finally decided maybe this guy shouldn't be on the medical staff. And so they kicked him off. And I was very interested in this phenomenon. Why had it taken them so long? What the hell was the guy thinking to do this? And so I asked the doctor who headed the group that kicked him off the medical staff, tell me, did this guy think, oh goody, I found a way to maim and murder a bunch of people and make a lot of money for myself? He said, hell no, Charlie. He had himself convinced that the gallbladder was a troublesome and evil organ, and that a doctor who really loved his patients just couldn't get that evil thing out fast enough. And you say that's extreme, but it really happened. And then, later in life, 4 or 5 decades later, right here in California, I saw a group of doctors top that one. In Redding, they had a hospital run by Tenet, bunch of former investment bankers of the worst kind. And they had cardiologists and heart surgeons acting in cahoots, and they didn't take out gallbladders skillfully, which were healthy. They performed heart surgery after heart surgery after heart surgery on people who didn't need it at all. And they had marvelous outcomes. As Norman Shumway of Stanford once said, says, nobody does better after heart surgery than the man who didn't need it at all. And of course, it was making so much money that Tenet with these investment bankers didn't think it was unnatural that a little community had 20 times the normal amount of heart surgery. They just sent all their other hospitals in there to learn how to do it. They kept sending the executives in. How can you be running a stupid little hospital that doesn't make money like this? Go up there to Reading and learn how to do this. And now, you'd think if I wrote that as a satire, it wouldn't work because it's too extreme. But it really happened. And I'll bet you anything that those doctors who are doing unnecessary heart surgery had some extreme version of my gallbladder surgeon's ideas. Somehow it was good for these people to get a nice set of new plumbing in the chest. And of course, it created a great scandal and cost Tenet hundreds of millions of dollars and so on and so on. But it really happened. Now, in a world where a lot of people take back surgery, how many medical doctors would want, I mean the better sort of medical doctors, would want every back surgery to happen in America that some back surgeon thought was good for people? Wise doctors wouldn't want that outcome. There's incentive cost bias in the diagnosis. It's just human nature. And it's ridiculous not to face these facts of human nature in terms of creating the incentives. And if you're a little tough-minded, you can have a whole system where instead of being paternalistically trying to prolong life, no matter how awful the life is you're performing, you say, the hell with it. The patient doesn't know what I'm doing. I'm the doctor. I'll be the adult. And that's the German health system. Let me tell you a true story from the German health service. We had a guy in my hospital, our hospital, who did lithotripsy. 10,000 lithotripsies he did. Death rate, 0. Cure rate, 100%. That's my kind of a doctor. Of course, you can only do that in lithotripsy or something like that, but it was a fair stunt. And he goes over to Germany. Of course, he uses these machines where they poke people and look in and what have you with cameras. And he goes to a German doctor in the health service, and the guy's a gastroenterologist. And he says, come along. He says, we'll do this case together. And the guy's sent in. It's the first time he's ever seen a specialist. He's been in the German health service in primary care. And the guy pokes this thing into the body with a camera and so forth, and is twisting it around with knobs. And he says to my friend, he says, what do you think that is? And he says, adrenal cancer of the kidney. He says, will you settle adrenal cancer on the kidney? And my friend says, yeah, that's what it is. He says, well, he says, we know that these ordinarily come from metastasis in the lung. Let's look at that. And this is a gastroenterologist. He sticks the probe into the lung and snips part of the lung and takes it out and says, well, we're going to send this to the pathologist and we'll call you Monday morning and tell you how it comes out. And of course, it was a hopeless cancer, and they called him Monday morning and said, stay home, we'll send somebody with pain pills. And that's all the care he was going to get from the German health service. Now, is that better medical care or worse? I think it's better. I think it's better. And you can say that's pretty extreme. I'm all for doing anything that has hope, but a thoroughly metastasized cancer late in the game, I think that what we do in this country is barbarous, and I think we do a lot of it because Medicare pays on a per item basis. And I see these doctors hanging over these dying patients, billing, and cross-referring, and so on and so on. What they're telling the family is, don't worry, Medicare's going to pay for it. Don't worry, Medicare's going to pay for it. This is not doctoring. This is evil behavior. Now, you can say it's delusional. It's not really evil. It's delusional. I think it's evil, and it shouldn't be allowed. And I think in adult play, and they don't allow it everywhere. Kaiser doesn't allow this kind of folly to the extent other people do, neither does the German Health Service. So I think we ought to have hugely different incentives where this barbarism doesn't go on. I think if you have somebody with a hopeless terminal cancer and you cut off both arms and both legs and are feeding them with a tube, the people who are doing it are out of their minds. If the patient wants it, tell them to go to another hospital. You know, that's my view about this endless, unwise intervention at the end of the life done out of a conscious and subconscious love of money. It shouldn't be allowed. Now, I'll tell you a story about...
Let me ask one question.
Yeah.
So, if you went the other way, there's basically no payment system that cannot be gamed. That's the other problem with the incentive structure is that so if I said, let's pay people on a salary, I would have predicted that Robbie Pearl's team would go home at 2 o'clock in the afternoon and not do anything for anybody, right? So if you're
right.
following the incentives all the way through, my puzzle for Robbie, and to some extent I know Arnie also thinks a great deal about this because he's working trying to make primary care incentives work, is why are you coming up with incentives that don't completely go wrong in the other direction? Because the great American fear is my doctor's going to stint and skimp on my care under your incentives and give me the person who's doing too much rather than the one who's doing too little.
So I think it's a great question, Atul.
I want to do it about right.
And there was a great study done actually out of Stanford on tenured professors. And you'd think that they would all go home at 2 o'clock in the afternoon. They've got tenure. They worked an amazing amount of hours because it's their identity. And I think that that's the piece people forget in healthcare. Why did we go to medicine in the first place? A lot of other things we could have done. Why did we spend 10 years of our lives, the most enjoyable 20s, being physicians in medical school, working 16 hours a day, 7 days a week, and being residents? We did all of that because it's who we wanted to be. And I don't really worry. I think that what we haven't done is to recognize some of the things that are less sexy. Preventive care.
Well,
What we know is that if we manage blood pressure well, we can eliminate 40% of strokes. Why would we not want to eliminate 40% of strokes as physicians? What we know is that by doing colonoscopy, we can lower the death rate from colon cancer. Why would we not want to do that? And I think the other part that sits back in physicians' mind are two: reputation and malpractice. So I think the chances of any physician in a prepaid system skimping on care is exceedingly low. But I agree with Charlie. I teach at the business school. Tell me your financial system, and I'll tell you something about the behaviors that result. Pay people on a fee-for-service basis, and pay them twice if you get a complication to correct it. And the likelihood is they're going to tend to do things that otherwise add very little value, and that's why I go back to this notion of the patient. And contrary to a little bit what Charlie said, in Kaiser Permanente, we don't try to shape what physicians do and patients do relative to the choices they make. What we really want to do is make sure we tell them the truth about their diseases.
yeah, well, I accepted you. I think you have a much better system than the rest of us.
Yeah, but I'm a surgeon, and I'll tell you, I lie to my patients. I tell them I can make you a lot better than you think you are, because that's how we think as surgeons. And I have to start saying, I can fix that cleft lip for you, not the first time, but the third time. But it may not get you all you want. Let me give you the truth. Let me not show you my 3 best pictures. Let me show you 3 average pictures. Let me show you the worst, the middle, and the best. However we're going to do it. I think we leave that in terms of informed consent. We believe that in terms of our training. We just don't practice it. And I think when we start practicing that, we're going to be much better physicians and much more compassionate human beings.
Well, obviously, we all leave. Our announced aspirations are always larger than we attain. And we want to live in a world where our announced aspirations are better than what we attain. We wouldn't want the reverse. But, and I don't think incentives is that difficult. There was once a state, and it didn't like all the rattlesnake bites. So it paid a very large bounty for a rattlesnake head. And of course, a lot of people started raising rattlesnakes. It's just the way the world works. And medicine is no different from anything else. And if you will pay an ophthalmologist X dollars for a treatment for glaucoma and X dollars plus Y dollars for treatment for glaucoma, which plus a little conjunctivitis, they'll find a hell of a lot more conjunctivitis than really exists. It's just the way human incentives work. And a lot of the doctors feel they're being abused. They're unfair, the government's limiting their income. There's a million ways to rationalize sticking an extra diagnosis on the card and getting more money. And I think that what you have to do is be wise enough to know which incentives should be changed and courageous enough to correctly choose them. If I were running the medical system, how would I pay for cataract surgery? I'd pay per item. I'd pay a guy who really knows how to do 60 of them a week, and they'd be way better outcomes than if all the ophthalmologists in the world did 4 each a week. And it would be way better for everybody. And it's not that much trouble to drive an extra 10 miles to go to the really experienced. But you'd be crazy to pay everybody a salary for the year. I mean, how nutty would you be to do that? Of course, they'd be taking trips to Europe instead of doing the work. But of course, but on other things, I would no more give the average psychiatrist an unlimited budget to do anything he thought would help the patient. Our hospital does pay the psychiatric expenses of the workers. And what I noticed was whatever the maximum limit was in our plan, that was the amount the patient needed. There was no exception. So what did I do? I chopped it way back. If they were to rob me, I left enough to pay for an acute stress depression, and after that they were on their own. And it's adult behavior instead of just letting these things run in some crazy way. And it isn't that hard to figure out what ought to be incentivized. We ought to give the internal medicine doctors a little less tough incentive and a little more time with the patients. And we ought to be a little tougher on some of the other stuff. And what happens is that as we make legislation and rules, everybody that's making a lot of money out of the system as it is gets together and exerts pressure, and they get by with bloody murder. And that's why we have the system we have. And it's obscene. It's obscene. I once saw a correction. I'm going to tell one final story because I think it's such a good story. And it reflects so ill on me. And I think I need more of that. My doctor once came to me because he noticed chalk in his stool. And he had 17,000 patients. He headed the whole medical department of the Edison Company, which takes care of all the patients. My personal doctor, wonderful man, sensible. And he said, Charlie, thoroughly metastasized liver cancer, totally hopeless. He said, Charlie, I'm tired. It's affecting me. I don't have enough strength to make the correct decision. I don't trust my own profession. He says, you make the decisions. I want to live. Well, I should have told him, the hell with you. You know, we both have German names. We can handle it. But I didn't. I said, well, the only people I've ever known that licked these hopeless cancer had extreme experimental chemotherapy. There's only one place that does that. So I said, he went there. And they tortured him with a pump they implanted that pumped poison into him. He suffered the tortures of hell. They treated him terribly. I just did him more injury than you can shake a stick at. And finally, he had all these tubes in him, but he was a strong man. And he reached out with his big arm and he pulled all those tubes himself. He fixed my ignorance for me. That was a good doctor.
Laura, you've written a lot about behavioral factors in the healthcare delivery system and how they're growing in importance and how we're not really addressing them. Could you interject how that fits into your vision or how the vision that you cast for the future and how we address those?
Well, these are all behavioral factors.
Let's see if she does
It's true, but I think some of the behavioral factors are occurring outside of the medical system altogether. That is, if you want to keep people healthy, it's happening not in a physician's office or in a hospital, but it's happening where they live and where they work. And, you said some of these things aren't sexy. That's not sexy either, saying I'm going to get people to sit less and to eat better. And we know very well that that's one of the best predictors of people's health over the long haul. So if we're going to get serious about it and get serious with incentives, we should be incentivizing healthy behavior.
Atul, how in the people you've been interviewing in your studies, how have behavioral factors been dealt with? How do they play into what Laura was talking about? And how do you see we ought to be addressing them differently with our patients?
So it's hard because I've tackled first surgery, and there your chance for your behavioral factors to control how well things are going while you're asleep are more limited.
But in the more recent studies.
But then as we began moving towards work in childbirth, where we're tackling C-section rates, for example, and how you begin to bring C-section rates under control, and at the end of life, it's been coming out of this curious recognition that where the healthcare system interacts with the behaviors becomes really sort of fundamentally important. Here's a nice example, and I think it really relates to some of the work that Arnie's been discovering in primary care. If you get the incentives right, the primary care physician ordinarily will say, look, I've got really complex patients. They don't take their medications. They are not following through on adherence. They're not sticking to the plan that I give them, and what am I going to be able to do about it? And then I'm interviewing folks who have a different set of incentives that are saying that, look, if you get the blood pressure under control and you have them on, and they have fewer diabetic crises and have fewer days in the emergency room, you can keep half of all the money that gets saved. And the fascinating thing is that then they discover really simple things. Like when the patients come in, they say, bring all of your medications, and they unscrew the jars and they count all the pills in the jar, and they say, why aren't you taking your medication? And they'll tell them about why that they're not. Either they don't like it, or they can't explain it, or that they can't afford it. There's a variety of reasons why that you discover underlie the human behaviors. And I think the idea that we can simply just expect the incentive for the patient to get them to do things they don't necessarily like to do, like eat lots more vegetables, is harder. But when you have a partner with you who is made, especially around people who are have particularly fragile health, are more prone to end up in the hospital or end up in the emergency room or those kinds of situations, that they're aware of their fragility and are more willing to partner with you and make it work along the way. And I suspect this is what you're seeing, Arnie, yourself in some of your, what you've called ambulatory intensive care.
Yes, absolutely. We've been complementing that recently with a national study that we're wrapping up of different types of medical specialties in community hospitals, trying to understand what's different about those doctors that perform exceedingly well on both meeting patient goals and on burning less health insurance fuel in the process. And the three themes that have emerged from this national study, which actually we called American Idol in Medicine until we got a letter from the lawyers, and so we've changed the name. But what we learned is that in the high-performing primary care practices, we saw three things that fundamentally differed from those in the middle of the distribution on quality and affordability. The first was that and Atul mentioned it in his book, these doctors, they found ways of communicating to the patient that the patients personally mattered to them and to the team. And that this notion of I have your back was one of the features that emerged, and I think does make an enormous difference. I think patients are a little bit less interested in doctor shopping or imaging study shopping if they feel that the doctor and the doctor and the people on the doctor's team are really on their side and personally care about them. That was something that came and made so much sense. The second thing we found was that the doctors who were performing better on lower cost and better meeting patients' goals also had an expanded vision of what their job was. It wasn't simply to produce the perfect office visit, but it was to take a role of stewardship for guiding their patients' trajectory through emergency rooms, in the hands of hospitalists, in the hands of other medical specialists. And that's something that I was never taught in medical school. It's an interesting evolution. And it also actually resonated with a number of the themes that you mentioned in your book. I'm thinking about some of the clinical examples. And so it was, even though it's a completely different branch of medicine, it's primary care, not cancer care, but it strongly reinforced it. And lastly, we saw that they were not trying to do all these things alone. I mean, we know that most primary care doctors, for example, if they simply had to deliver preventive care perfectly, it would take about 18 hours a day, so they don't deliver care perfectly, no surprise. So if you wanted to move beyond that and provide better care more affordably, the list of what you'd have to do would probably expand to 24, 36 hours a day. And so we saw universally that these doctors had not invested much in physical plant. They were in relatively modest offices. They were sitting around in a sort of bullpen-style table with more medical assistants, and they took the money they weren't spending on physical space and machines, and they invested it in medical assistants to kind of help them leverage their skills and their knowledge, so that some of the things that doctors are currently doing that is not a good use of their time was done well by people that worked with them. So that's what we found. I also say, just a matter of history, the hospital that Charlie mentioned, just by accident of history, I was brought in by the Office of the Inspector General to try to sort out what in the world happened. And I'll tell you something, is that Charlie's intuition was right. I mean, these doctors believed they were doing something great for the patients. They believed that they were on the cutting edge of medicine, I guess in more ways than one. But what he said is that they were preventing what they referred to as widowmaker's lesions, and treating them, and then that eventually medicine would catch up with them. So these people were not rascals. I actually won't make a judgment. That's not my specialty. But I will say that they believed they were doing the right thing, even though what they were doing was catastrophic for their patients. And with Robbie here, I need to say that what really untangled this mess was that one of Robbie's patients, a member of his medical group, was on a hunting trip up in Northern California and had indigestion and was brought into this hospital and was told, you need major heart surgery now. And something inside, maybe he trusted Robbie's medical group, said, I think I'm going to keep driving. I head from Reading down to my doctor in Oakland, who then did a complete, deep, thorough imaging study and said, sir, there's nothing wrong with your coronary arteries. And then the patient fortunately called the California Attorney General, and then one thing led to another, including a disaster for stockholders in the parent company.
But lesser versions of that Reading syndrome are shot through all medicine and all life.
Yeah.
And human systems have to take them into account.
One of the things that strikes me as we're sitting here is just really how American healthcare is in denial. And I think we need to understand that. When we look at the global view, I think we're like second to last amongst industrialized nations in male mortality, and last in female, last in childhood mortality. We tell ourselves the great system we have, but when we actually step back and look at it, we do a poor job. I think Atul's book is brilliant. I think it's the best book I've ever read, actually, on the end of life and aging process that sits there. And And as he talks about, we tell ourselves the wrong story. We talk about how wonderful these places are because they're so safe. We fail to see the pieces that are there. We fail to see the lack of preventive services. I tell people, if this were 7 years ago and I said, I wanted to get people to carry an iPhone, the CFO would be telling me, too expensive. We got to buy it for them and train it for them. And yet, everyone in this audience bought one, carries it with them, checks it every 8 minutes, and sleeps with it. All right? And we have not in medicine figured out how to make their life convenient, because it makes our lives less convenient. Whether it's going to be a video linkage, whether it's a physician, that patient up in Northern California, whether it's going to be something about preventive services and health and nutrition. What we know is that diabetes is an epidemic. What we know is that sugar sodas contribute to it as severely as cigarettes can contribute to lung cancer. And we don't do anything about it. We know all these things. There are things that we can do. And my diagnosis of American medicine is it is in denial. We tend to tell ourselves how great it is. When you step back and look at it, and end-of-life care to me is the epitome of that. And I love what Charlie said. How many people we torture, not because they really want us to, because we simply haven't told them the truth. And I believe when we start telling ourselves and our patients the truth, we actually will, to Arnie's point, make American health care not only better quality, better service, and more compassionate, but less expensive.
Arnie, you studied that. One of the CERC projects had to do with end-of-life care and cancer. Can you describe how you structured it? And Manali was very much a part of that, but and what you found?
Absolutely. You know, here at Stanford, you know, one of the glories of this university is the heavy emphasis on bringing together people from different disciplines. So that's, you know, one of the secrets to what we do. And then before we try to come up with, we try to imagine a better way of delivering care in some domain of care, we go through a systematic process, as we did for cancer care. And we hold ourselves responsible for coming up with a new way of delivering care that not only would better meet patients' goals, but also would leave more of their money left over to spend on other things, K through 12 education, child care, you fill in the blanks. And we do it by a 4-part formula that one of my fellows pointed out to me bears an uncanny overlap to 18th century Welsh advice on how to start a good marriage. But it basically, the fellows systematically comb through 4 categories of knowledge, and they fit into the categories of old, new, borrowed, and blue. The old part is, you know, we begin by, you know, looking at the existing evidence on what changes in care delivery methods cause, you know, better outcomes at a lower cost. The literature is there, but it takes patience to sort through it. That's the old. The new is we basically say, look, look where we are. You know, we sit at the border of the world's, you know, greatest source of innovation in information technology, and so we say, are there things that we could borrow from information technology and other rapidly emerging sciences that we might graft in that nobody's thought of yet? That's the new part. The borrowed is that we do positive outlier research. You know, as I described, in the area we're studying, we send our fellows out to look at places that are getting great results at a much lower cost, and we do that globally. We sent a team to India to study coronary artery surgery at a hospital that produces it 95% less expensively than we do here in the U.S. And they produce it, we learned through our analysis, 40% less expensively, even if they had to pay American labor and non-labor input costs. So that's the third advantage we give our 30-year-old reimaginers of healthcare. And the blue part is, again, very overlapped with what Atul has been doing at Harvard, and that is we take advantage of, you know, the discovery at our engineering school of human-centered design, and we have our fellows interview scores of patients and clinicians in whatever area we're studying, and try to draw them out on what their most deeply felt unmet needs are. And then out of that knowledge base, we progress. And Manali Patel, who's here with us today, was the leader of our team in redesigning cancer care 4 years ago. And she spent a lot of time listening to cancer patients and their clinicians, asking them what it was that most deeply dissatisfied them. And that knowledge base substantially informed the new model that Manali is now pilot testing in 5 locations across the U.S., diverse health systems. But one of the things that we heard from them is almost universally is, I had no idea about the consequences of these aggressive interventions. I just had nobody really explained to me where, you know, what my odds were and what the consequences for my quality of life would be if I opted for aggressive intervention. So part of the model that Manali's testing involves systematically having the kind of conversation that Atul mentioned in his talk and better, even further specified in his book.
Laura?
Yeah, there are surveys of younger to older people asking them about their greatest fears. And older people are afraid of basically everything less than younger people are, except for one thing, and that's not death. They're much less afraid of death than younger people are. They are afraid of being caught up in some medical intervention or a nursing home, somehow being out of control at the end of their lives. And that's at the top of the list of fears of people who are closest to the end of their lives. It seems that with age, people do a better job of coming to terms with mortality than the medical profession so far is doing. And if we could honor people's wishes, as you're saying, if we could ask them what they're afraid of, and as Atul is arguing, ask them what their goals are, and then begin to design a system that helps them achieve those goals and preserve those values, then we're going to come a long way toward improving healthcare.
Atul?
One of the things that strikes me out of this conversation, it's interesting to me, is, especially being here at the home in Silicon Valley, is a innovation iteration gap. So many of the major breakthroughs, you mentioned the iPhone or Facebook or other things, are really with young innovators who are solving their problems. You know, Mark Zuckerberg, sitting in his dorm room at Harvard, was trying to solve the problem of how do I get pictures of hot girls in Harvard. You know, that was Facebook. And then it became, how do I make that possible around other universities? And even to this day, I have friends who work at Facebook, and on Friday night at 2 a.m., you dread the email from Mark Zuckerberg because he's going to be trying out the new game on Facebook. And if it doesn't work very well and it's not very fun at 2 in the morning, you're going to hear about it. Well, our innovation gap is that the people who are the innovators are often at an age where they don't know what the needs are at the population that want the innovations. And so the iteration cycle is much, much longer. So Arnie's describing, you know, what is the experience and innovation that we need for people who are dealing with either very complex chronic disease or with a cancer diagnosis here. And you have to send the fellow, the researcher, out to go talk to these folks for a little while. And talking isn't enough. You know, what you want to do is live with them. You want to be with them day in, day out and understand what are the gaps and puzzles and struggles in their life. And out of that comes the chance for iteration and innovation that starts to solve those individual problems. And so a lot of the problems we have, I think, are a mix of, we have the wrong incentives, but even when you've got the right incentives, we have the gap that people like to work on and fix problems when you're the engineer or you're the scientist. You often are solving problems that are right in front of you and feel very present to you. And we have to kind of venture out of the box into these other worlds where you can have enough of an experience of these folks' lives. And I think that's what I got away with in writing this book and others, is that I more or less just spend enough time as a journalist or an anthropologist way, an untrained anthropologist, and you can call that a journalist. And and I get to hang out with people. And as a doctor, I never get to do that. But when I'd ask my colleague, like if I asked my colleague, can I hang out with you in clinic today just to watch how you do your work? They'd be like, are you crazy? No. But if I come in and say, hey, I'm writing a story about geriatrics, and I've never been downstairs to this clinic you guys have, can I hang out with you for a few days? And you get permission, and you kind of follow, and you understand, and then you start tracking somebody through. Or for a documentary we did with PBS, we filmed patients going through their cancer treatment over the course of 2 years and just followed people with cameras. And it was sort of unbelievable. It was this discovery process of what the real conversations between a doctor and a patient and a family are like over months of time, how the trust builds up, but then also how this crunch moment comes where your second line therapy didn't work, and how are we going to talk about that now? And so I'm going on a little bit of length, but I think the concept of being in a place really devoted to innovation, about moving out of the drug and device also into the health system delivery world, but how we innovate these systems and solve these problems, is about sticking close enough to people as they go through either trying to be better from nutrition and wellness point of view, like why does somebody with severe diabetes continue to eat poorly? And what is it really that's the barrier in their life, and how do we innovate around that? Or what are the barriers of delivering the care that Charlie's talking about, even among the folks that have got the right incentives in hand?
Well, I would argue that some of these solutions have already been invented. Kaiser is getting the best young internists now on average. And Kaiser keeps them in these little pods, and they all have a life. Half of them are female. They don't want to work 100 hours a week. And it works for the doctor. It works for the patients. The patients love these pods. and they don't allow the doctors to go crazy with a lot of stupid interventions on the dying people. A lot of these problems are pretty well solved by Kaiser, and the rest of us won't learn. We just let Kaiser go on, and it's like we have a rule in life. We won't learn anything from Kaiser.
Let's hope.
There's nothing wrong with learning from Kaiser.
We do want to open the floor now for questions, but before doing that, if I could ask each of the panelists to be thinking for the next 8 minutes or so while we're having questions. Maybe we'll go down the panel just as we opened with a minute on a description of the key problem with healthcare in America today. Maybe we could finish by one thing that we could be addressing in the coming year to make a dent in the problems. So let's open the floor for questions while everyone's thinking on that topic. And we have some microphones. Please come up to the microphone if you'd like to ask anyone on the panel a question. Go ahead, please.
The one thing that I wanted to ask about is something that Dr. Gavande said at the beginning of this discussion, which is the fact that our technology has, I forget what it was you said, but what struck me about 30 years ago when I started out in healthcare, I've been a healthcare researcher, is that not only does the technology not quite apply where we put it, but we actually have failed as a society to examine the ways in which those technological advances in healthcare and medicine, it exceeds our human capacity to understand what it is we're doing to ourselves. And we just had a discussion about the forget the name of the initiative in California, the compassion dying thing, physician-assisted suicide. The discussion a couple of weeks ago, and it was very contentious at times, and it became very clear to me that the problem was the fact that patients, I think, finally want to be able to exert some control over their own lives and deaths. And even though physician-assisted suicide is one of those things that is officially frowned upon by hospice and palliative care, but the thing is that there's a meeting in the middle, and we've been missing it, and I don't know why. It just seems to me that we're losing track of what we want and what we need as people. And I've been looking for an opportunity for many years now to quote the late Jonathan Mann. When I was a student at Hopkins, he said, we should start caring less about p-values and more about human values. So I've been wanting to say that ever since I heard him say that. So from the depths of death, there comes Dr. Mann's last words. So I just want to hear about what you have to say about that, because I think that we're kind of talking in the wrong direction. We're talking past one another and past the patients. If we're not looking at this, we're misdeploying technology.
I'll jump in real quickly, which is to say a couple caveats. At the end of the day, I'm still a surgeon, and I sort of believe in technology. And we've come through a century that has allowed us to have, I think there is no better era, I make the case even in the book, to be alive and to grow old. That, we've replaced a 10-cent aspirin with, yes, a $25,000 hip replacement that gives you 10 or more years of functional life and independence and values that people want. But the big difference is that we have not been very articulate about what the goal is besides health, but instead being able to talk about, are we deploying the technology for what goal? What is the goal for somebody? So my mother underwent a knee replacement, and she wanted freedom from pain, and she was not really interested in walking farther. In fact, she still has not given up the wheelchair ride in the airport because she just likes that better. But then there's another person who says, look, I want to be able to run again. And understanding what those goals are and what we're actually deploying the technology for, and how many people are we actually achieving what they expect versus what they don't expect. And I think that has been the missing link, and I think it's almost more a cultural matter than anything else. That if we have clinicians and patients who understand these concepts, that we take seriously the idea that our leadership has got to be devoted towards solving the goals that people have, then we as clinicians demand
that the incentives change to make it possible for us to do these things and demand the structures and systems that begin to make it go that way. And I think we as patients and family members can also demand and insist that too.
Yes.
Thank you.
Go ahead,
I've
please.
practiced medicine for almost 50 years, so I have a little different perspective on a lot of these things. Basically, we're all patients. We all want to be heard. We want to express our fears and our desires to our physicians. As long as we have a fee for service and doctors are not adequately paid to listen to us, we won't get heard. We pay lip service to capitalism, which allows a drug company, excuse me, to charge $1,000 a pill, but we won't pay people to be geriatricians or primary doctors, nor will we pay people to go to medical school to serve the country. I have a granddaughter who's a second-year resident at UCSF, and my son has paid, I think, something like $220,000 for the education of this child. It's no wonder that so many medical graduates gravitate to high-paying specialties, and that's not what the country needs.
Great. Thank you. One more question, please, and then we'll wrap it up.
All right, regarding about changing health behaviors, we talked about incentivizing health behaviors, but sometimes there are like systematic problems that affect the ability of patients to change their health behaviors. So how can the health system like kind of implement these social changes or like help to do that?
Laura?
Workplaces and schools are really good places to start. We spend an awful lot of our time either at work or school, and what we could do is to change those environments so they incentivize healthy choices. I mean, when the default options are healthy options, people tend to do them. And when they're not, they don't. So I think we could look at those kinds of environments and make some pretty important changes. You were saying, you know, soda pop in schools should not be an option. So it would be changing those environments, I think.
Well, thank you for your questions. Let's start the other end. Arnie, something we can do in the next year to make a positive impact.
My inclination would be to, for clinicians who are interested in improving value in meeting patients' goals, to begin to think more actively about what we might borrow from our colleagues who are developing smart systems to make everything easier, and that's where I would invest effort. I think the things that I am most excited about, in our collaboration, here at Stanford is our year-long collaboration with the AI Lab, specifically focused on how do we develop smart systems to make it easier for patients and clinicians to recognize and pursue patients' goals.
Thank you. Robbie?
I'm going to leverage off what the gentleman over here spoke about. I think that we need to increase what we pay to primary care. I think we need to incent them to take more time per patient. I think we need to start training more residents in this important area. And we just need to recognize that a primary care physician controls $10 million. And the last thing we want to do is be squeezing him or her. What we really want to be doing is giving the opportunities to impact the lives of patients along the lines that Tool has well defined to improve the maximum quality, and that simply takes time. We've got to give them the time to accomplish it.
Thank you. Laura?
At the Center on Longevity, we're beginning a project to look at a decision context that could improve decision quality. So it's not only the physician who's making decisions about a patient's health care and choices, but also family members, individuals, children who run in and fly in at the last moment and go, stop, you can't do that to mom. And so how can we find better ways to provide environments, supplement with technologies and so on, this context so people aren't making decisions under speeded time tasks, and with emotions running high and lots of different inputs. We think we could do better by changing that context.
Charlie?
Well, I agree with all this talk about internal medicine having a little more time with the patients. There's been too much speed up. My mother's internist raised his son, who was a doctor, with the following injunction. He said, don't take too many patients and make a friend of everyone. I think we need a little more of that in American internal medicine, and we ought to pay for it. But I don't think that's the principal problem of medicine. I think you can look at medicine as just a place with a lot of nasty pustules that ought to be excised. And they're not very hard to find. These pustules are gucking out this nasty green fluid, and they're just all over, and you just change the incentives, and one by one you squash them out.
Great. A tool.
I think it's ironic we have 3 surgeons on this panel, and we're all talking about primary care. And I think what the story is that we're now at a place where about 20% of Medicare patients are no longer under fee-for-service payment, but in fact have clinicians who are under new incentives that allow them to be rewarded for generating more value to the services they care. And all of those under those structures are places that are rapidly discovering the primary care physician, the geriatrician, the palliative care doctor, the range of people who've been neglected, and starting to recognize, you know what, we will reward you for every avoided emergency room visit, every avoided hospital visit, every person who's doing better. Some of them are rewarding people at unbelievable levels of pay, literally 2 or 3 times the pay they currently get. And I think that we're going to see that unfold. So what happens in the next year, I think, is the discovery and the reinvestment of primary care as a team sport, which requires, I think, the most important thing, which is being able to foster leadership skills among clinicians for building organizations, which they teach you nothing about in medical school, nothing about in training, and we don't learn about in our practice in quite the same way. So I think some of those leadership skills and capabilities of being able to build this will be crucial for the next few years.
Great. Let's have a round of applause for our outstanding panel. And thank you all for being here. Have a safe journey home, and we look forward to continuing the dialogue.